From 2018, the new goals of patient care forms will start to replace the current Do Not Resuscitate forms in all hospitals across WA. This will encourage shared decision making between patients, family, and doctors, and will ensure appropriate care in the event of a patient's clinical deterioration. Difficult decisions to limit a patient's treatment tend to occur during crisis situations, especially during MET calls. 2/3 of MET calls occur after hours, resulting in patients being treated by clinicians who don't know them, and often when the patient is unresponsive and without a surrogate decision maker present. This results in patients with poor prognosis being inappropriately resuscitated or invasively ventilated against their wishes. To avoid this issue, it is important that senior doctors have these discussions with patients, especially those who are likely to deteriorate early in course of life-limiting illness or within 48 hours of admission. Discussions should be in a calm environment with family and carers present. Clear documentation of the discussion and the patient's wishes need to be easily accessible by any clinician managing the patient, particularly in the event of deterioration. This is where the goals of patient care forms come in. First, ensure the document is labelled for the correct patient. Clarify the patient's diagnosis, prognosis, and comorbidities. This is a good opportunity to discuss the realistic goals according to probable outcomes. Decide who the patient would like to speak on their behalf if they cannot speak for themselves. This is known as the person responsible. Identify relevant documents relating to their care, including Advanced Health Directive, Advanced Care Plan, and Enduring Power of Guardianship. Current decisions regarding sealing of care are focused too narrowly on cardiac arrest and CPR, without incorporating a patient's values or identifying all treatment options such as performing all life-sustaining treatment with the aim to cure, prolonging life with a treatment ceiling, active ward-based management with symptoms and comfort care, optimal comfort treatment for palliated patients. These goals are specified in Section 2, which group appropriate treatment options with each goal. This addresses the issue on the old DNR forms, which allowed contradicting treatments to be individually selected. Fill out Section 3 in as much detail as possible. Who was present during the discussion? Was the patient able to fully participate in the discussion? How will the patient likely respond to CPR and critical intervention? Explain to the patient that CPR has poor survival outcomes in certain patients, with the potential for further impairment, and discuss whether it's appropriate for them. What are the patient's needs, values, and wishes? Capture the patient's quotes to document this in their own words so that it's meaningful, rather than just ticking boxes. What was the rationale for the agreed goals of patient care? Did you come to the decision together? The final section of the Goals of Patient Care form allows it to be extended beyond the current admission for 12 months, or until a date specified by the consultant. The summary can also be amended during the admission by completing a new form and providing reasons for the change in the patient's progress notes. Remember, in the absence of a completed Goals of Patient Care summary, the default is full resuscitation. So have this discussion with patients early, so that we can respect their wishes and give them the appropriate care.